I would like to welcome everyone today to the online supporter webinar, and thank you all for joining us. My name is Robin Sands, and I'm the head of Field Human Resources, and my role is to support our field staff that do such wonderful work across the world. I started with MSF in 2005 and worked in the field and continued this for about 4 years. I then took up a management position overseeing our people and our projects in around 9 countries around the world from the Paris operational office. I returned home in Australia in 2010 to continue my current role. I'd like to give a brief overview of the event today. Today we have Jennifer Tierney, the Director of Médecins Sans Frontières Australia and New Zealand. Jennifer will provide you an update about MSF and the work we have undertaken over the last 6 months across the globe. Also joining us from Melbourne, we have Dr. Madeline Finney-Brown, who will discuss her work at the Wheel Civil Hospital in South Sudan as a paediatric doctor. We'll also hear from MSF Advocacy Coordinator, Aaron Jegan, who will be talking to us about his experience in the field with refugees. So now I'd like to pass to Jennifer.
Hello, and thank you so much all for joining us today. I want to start off just by saying that the webinar today is going to be recorded. And of course, importantly, I want to acknowledge the traditional owners of the land from which we are broadcasting today, the Gadigal people of the Eora Nation. I also want to acknowledge the traditional owners wherever you are and pay our respects from MSF Australia to their elders past and present. And I finally want to note that this land has never been ceded. Always has been, always will be Aboriginal land. So a quick introduction, you can probably hear from my accent that I am here in Australia by way of the US, arrived a few years back after some time working with MSF in my past history and became executive director of MSF Australia about 1.5 years ago. And the first thing I want to note is that, I kind of got thrown into the deep end as we all did when COVID started. And it's a heck of a team that we've got here, not just here in Australia, but in our medical humanitarian projects in 70 countries around the world, and also in our offices that support those projects from Tokyo to Hong Kong to Paris to Argentina and Brazil, et cetera, et cetera. And most importantly, our team members that keep the lights on and keep the vaccinations going into arms around the world, you. We, at the beginning of COVID, had a moment of panic like any other organization would have that, oh my gosh, we have this massive humanitarian medical emergency, the biggest we've ever seen. And our operations are going to increase, and we're probably going to see a dip in funding, and just started scrambling around our panic in that moment. The miracle is that we did not see that drop in funding, and that is much to your credit. So I just want to say, first of all, thank you for sticking by us this year. And it's not over. We encourage you to stick by us as we move forward. I will talk to you a bit about the challenges that we have ahead. So where are we at was the first sort of question. And I want to frame this in that MSF right now is sort of in a post-COVID settling phase. Obviously, COVID isn't over, but we can't continue to be in emergency catch-up mode forever. So a few of the things that I wanted to point out is globally as an organization, we had a huge challenge to basically get ourselves in line with how do we work now. I think that was just something that was common to all of us. We now here in our office are, into remote working. We've settled into ways of managing teams when they're here and working from home, etc. So tick on that box. It's a process that we'll continue to go through, but nothing unfamiliar to you. The unique challenges to MSF, however, that I want to bring up are threefold: field human resources, supply to our field, and then continuity of care, most importantly for our patients. So on field human resources, one of the things that I've spoken to some of you already about was the massive challenge of continuing to get international staff, particularly specialists, into our medical humanitarian projects in 70 countries around the world when you have flight paths that are shutting down, huge inflation in the prices of flights, difficulty of getting people into quarantine, constantly changing and opening and closing borders. And our field HR team here, led by Robin, to my right, did an incredible job of getting more than 100 field team members out of Australia and New Zealand last year. That is about 2/3 of what we typically do in a year, but I'll tell you, they probably did double the work because of all of the things that were thrown their way. The happy accident of not being able to send as many international staff around the globe this year is that we really turned to our locally hired team members, and they absolutely took up higher level managerial roles, stepped into roles that they might not have in the past. And we actually, as an organization, responded to their needs in a much, I think, more agile and interesting way, which was remote training, support from HR in remote locations, etc. This has been an intention of MSF for a very long time, and COVID actually just accelerated our intention to make sure that we're providing more mobility to locally hired team members. So we're pretty happy about that. We're not perfect yet. We are far from. We have a ton of work to do in that regard, but it was a good kickstart. On supply, we have a very sort of Eurocentric supply system. And so one of the big things about that Eurocentricity is that all of our supply actually has to get checked in Europe to make sure it's up to standard. That's everything from medicines to personal protective equipment to the cars that we use. And we found last year that just like everyone else, when we were thrown into the deep end of competing for supply in response to COVID, that system and that sort of caused a huge bottleneck for us. So the Australia office is working with other offices in the region to decentralize our supply system and working in Southeast Asia and Pacific to try to ramp up our supply so that we have a more global and more flexible supply system. Two other benefits of that are, one, we think that it will decrease our carbon emissions, which is wonderful. And another goal that we have as MSF Australia and the movement is to look more at climate, our impact on climate, and our responsiveness to climate. And two, lowering the price and cost of moving things and lowering the price of goods for MSF so that we can put more money back into patient care. The final thing I wanted to mention is just continuity of care. The numbers have come out from 2020, and the operations that we had pre-COVID actually did go down by about 10% overall. Many reasons for that. Some of that was planned closures and then not being able to open up new projects. Some of that was projects having to shut down because of COVID infections or whatever it might have been. Some of it was repurposing projects to actually become COVID projects and not doing the same level and number of patient interventions that we might have done in the past. And some of it was just people not being able to get to or fearing to come to clinics and hospital settings. And so we did see a decrease in our sort of standard operating medical projects. What we didn't see was a decrease overall, however. We put COVID on top of those operational projects, and we actually exceeded the volume of operations that we would typically do in a year. So the big focus right now, one of them for our operational teams, is to make sure that we maintain continuity of care for maternal and child health care, for standard vaccination programs, malnutrition programs, surgical projects that we have around the world. And that will be a big focus of 2021. One thing I was asked to talk about is to just get away from COVID for a minute and say, despite the fact that COVID has been a focus, necessarily so, of the organization, other crises that often trump COVID still go on. One example of that is the conflict in Tigray. So Tigray is a region in northern Ethiopia. And actually this morning on my run, I was listening to, and I don't work for the New York Times, nor do I endorse any of its opinions, but I was listening to The Daily, which did a podcast this morning on Tigray. So if anyone's interested in hearing an outside MSF perspective, that might give you a little bit more of the political background as to how this happened. But a conflict erupted on November 4th as everyone was watching the US presidential election, clearly not unplanned, where the Ethiopian government started military action in Tigray, in this region, because they had actually launched a regional election despite the fact that nationally elections had been delayed, and the Ethiopian government was displeased about that. What ensued was population movement on a mass scale. So huge displacement from people's homes inside Ethiopia, inside Tigray, also people crossing borders, 60,000 people crossing into Sudan, for instance. There was also a large number of people killed, civilians being killed in the conflict. So we have seen, evidence of mass graves in the field. We've also, there's also been accusations and evidence of huge amount of sexual violence perpetrated against women. We found once the initial spike of violence receded a bit, that a health system that was previously quite strong with really good rural and remote healthcare clinics and great referral systems for the people of Tigray to be completely decimated. We visited many clinics which were, from an infrastructure perspective, destroyed. Some were bombed. Simple things like beds torn apart, mattresses missing, etc. People's health files have been destroyed. And so perpetrating really violence against the healthcare system so that people just couldn't access the care that they needed. We've also seen evidence and have growing concern around malnutrition rising in Tigray. This is not surprising in a context such as this. We're seeing higher levels of severe acute malnutrition and moderate acute malnutrition with children. And that is also a result of the violence. When people have to move away from their crops, when they're not able to farm, with farms being taken over by some military actors, and you're cut off from your food supply, you are going to see this as a result. We're also seeing evidence of boreholes and wells being tampered with. So all this to say is our work goes on despite and because of COVID all at the same time. I thought Tigray was a good example because it dovetails nicely into the two folks that you're going to hear speak now. So Dr. Madeline Finney-Brown is going to be our next speaker, and she is going to be speaking about South Sudan, which is in the region of Tigray. So let me tell you a little bit about Madeline, and I think you will be as impressed as I was when I read her bio. So hold tight. You will feel definitely like you haven't accomplished enough in your life after you hear this. So as a teenager, Madeline decided to pursue a career in medicine because she dreamed of working as a pediatric doctor for Médecins Sans Frontières. Throughout her years as a medical student and junior doctor, she kept this goal in sight. While studying, she undertook a lot of volunteering opportunities around the world, including in China, Madagascar, Ghana, Uganda, Fiji, and Belize. Additionally, she completed a diploma of tropical medicine in Tanzania and Uganda as a junior doctor in 2015. She loved her experience working as a junior doctor in Darwin, where she grew up, including some time spent in remote Aboriginal communities. In 2020, Madeline had the opportunity to undertake her first mission with MSF as a pediatric doctor in South Sudan, a place close to my heart. She describes it as the most heartbreaking, yet simultaneously rewarding and fulfilling experience of her life. Madeline is currently completing her pediatric advanced training in neonatology and general pediatrics in Melbourne. Madeline will share her presentation and describe her experience in the field. Thank you, Madeline, and welcome.
Thank you. Let me just share my screen. All right, so thank you, Jennifer, for that introduction, and thank you for the opportunity to speak today and share my experience in South Sudan. The title of my talk is "Freedom is not a gift, but a product of the struggle." And this was painted on one of the walls in the hospital I was working at in South Sudan, and I'm going to come back to that a bit later on. So this is me. You've already heard a bit about me from Jennifer's introduction. So working for MSF is something that I've wanted to do for a very long time, and you know, it's taken me a while to get to the point where I had enough knowledge and experience to be able to apply for MSF. So I was thrilled last year when I was accepted into the organisation, and it was around this time last year that I received an email saying that they were offering me a position in South Sudan. I didn't know a huge amount about South Sudan before going. I knew where it was. So I did what I think anyone in my position would do, and I Googled it. And when you Google South Sudan, this is what comes up. So hunger, squalor, violence, famine, death of a dream. And I think this is what a lot of people think about when they hear the word South Sudan. And I would soon discover that there was a lot more to the country than what these images portray. The project that I was working on is a paediatric and maternity service up here in a town called Awil in the northwest of South Sudan. the population of Awil is approximately 30,000 people, but our hospital was a referral service for the region, so we would have patients coming from all around the area. Awil is a predominantly Dinka area, so and it's very comparatively very safe and stable. So there's obviously ongoing fighting in other parts of South Sudan, but Awil, yeah, was a lot sort of more stable. So I completed 2 weeks of quarantine in Juba and then flew up to Awil, and this is the site that I was met with. So when I arrived in July last year, it was just the beginning of the rainy season, so everything was quite green and obviously very wet. And this photo was taken from the water tower at the hospital, looking out over Awil town. So this was my daily commute to work. So on the right, you can see the MSF compound where we lived. The hospital was about a 10-minute walk from the compound. We have to go directly through the marketplace, which was always, you know, you have lots of people saying hello, you'd meet some goats, some donkeys, and then onto Awil Civil Hospital. So MSF took on the Paediatric and Maternity Service at Awil Civil Hospital in 2008 and have been running these services since then. They work alongside the adult medical and surgical services, which are also provided on the same site. There are around 400 national staff working on this project and sort of 15 to 20 expat staff. This gives you an idea of our inpatient numbers. So the number of permanent beds is 150, but as you can see in this week in October, the number of patients admitted was well over 200 every day. And the reason for that is that this was in the middle of the malaria peak. So we had so many kids coming in with malaria requiring admission for treatment. And the bulk of those patients would be in the inpatient department. So we had extra tents set up, which are sort of permanent fixtures during the malaria peak season and then are taken down at the end of that. And this to accommodate that influx of patients. My role was predominantly to work in the neonate department, to care for the patients with tetanus, and also to work in the intensive care unit. I worked alongside 5 South Sudanese doctors who weren't paediatric trained, but were all very, very knowledgeable and very skilled. So my role was also to support them, and particularly if they had more complex patients, they would just come to me. But they also taught me a lot. And, you know, when I arrived, I'd never treated a patient with malaria, so I learned a lot from them, as well as supporting them. We also had a telemed service, which is available through MSF, where we could, if there were cases that we were all uncertain about, we could upload them onto the telemedicine website and get advice from specialists all over the world. So the neonate department. So neonates, we would admit babies up to 1 month of age. A lot of these babies would come from our first service, but we would also have babies coming from home or referred in from other peripheral health services. Around a quarter of the babies that we would have admitted were premature babies, and otherwise the rest were term babies who were unwell for one reason or another, whether that be infection, birth injuries, or congenital abnormalities. Even though we had limitations in the investigations and treatment that we could provide, the majority of our patients would recover and would go home. However, I still saw a lot of very sad cases, and there were times when we would diagnose a baby with a condition that we just couldn't treat, or you know, they would be so unwell that we just knew that they wouldn't survive. I still remember the first time I had to have that conversation with a mother, and you know, trying to find the words to tell someone that their baby is not going to survive is horrendous. And it's a conversation that I hadn't really had very often in Australia, but I had to have this conversation so many times when I was in South Sudan. And I think, you know, having the conversation that many times doesn't make it any easier. It's still just as hard every time you have to have that conversation. No matter, ordinarily the women would respond by saying something along the lines of, I know that you've done your best. I'm really grateful for the work that you've been able to do for my baby. And they would usually end the conversation by saying, you know, now it's up to God. And I think a lot of the families that I worked with in South Sudan were quite religious, and I think that helped them. But of course, a mother's love for her baby is the same regardless of her religion, regardless of her ethnicity, regardless of whether she's rich or poor. It's universal. But then so too is her heartbreak. So this was very confronting for me, and I took a lot of strength from the South Sudanese staff because I just felt that they were so strong and yet so empathetic in their care for these patients. So they were continually working with families who were experiencing loss, experiencing hardship, and yet they put their all into each and every patient, and they still maintained this sort of empathy and this idea of, you know, why they were there. These are two of our lovely nurse aides who worked in the neonate department. This is our birthing suite, which may look quite confronting, but the service provided in this room literally saves so many lives. So being able to have access to a skilled birth attendant, have access to potentially a cesarean if required, to the medications to stop bleeding, to be able to monitor the baby in the labour to make sure that the baby's not becoming too distressed. It's an incredible service that was offered, and and I think many lives were saved because of this. So on the day that these babies were born, their mother presented to our hospital in the 9th month of her 9th pregnancy. She was in early labour and she thought she only had one baby. The obstetrician examined her and thought, well, something's not quite right here. So he put the ultrasound on her tummy and discovered that she had not one, but 3 babies. She was very surprised, to say the least. She went on to labour and safely deliver 3 healthy boys. And that was, you know, thanks to the assistance of the midwife and the obstetrician to help guide these babies into the world. All 3 boys required admission to the neonate department. The smallest of the 3 was only 1.4 kilos, but they all needed help with feeding and with sort of monitoring their temperature and their blood sugar levels. The littlest of the 3 did become quite unwell and required antibiotics and IV fluids, but eventually they all sort of grew stronger and they all went home. So the other department that I worked in was the intensive care unit. So this was a surprisingly quiet day in our intensive care unit. We had 9 beds and usually they were all occupied, particularly during the malaria peak. This is generally more what it looks like. So the kinds of kids who would require admission were children with malaria. We would have kids come in with very severe cerebral malaria, which means that the brain is involved. So they'd often be in different states of coma. They might be having seizures. We would also have kids come in with respiratory problems and infections, with surgical problems like appendicitis, burns. We had kids come in with snake bites, with rabies, all different kinds of conditions. And normally in an ICU in Australia, you'd have ventilators, you'd have all kinds of high-tech equipment. We obviously didn't have any of that, so we just did the best that we could with the resources that we had. This is our resuscitation bed, so if any of our patients, like they were becoming more unwell, or if they stopped breathing, or if their heart stopped, this is where we would bring them to attempt to resuscitate them. Like I said before, I also cared for the patients with tetanus. So when someone is infected with tetanus, they can have really painful muscle spasms. And they are triggered by any kind of external stimulus, so light, sound, touch, any of those things can trigger their spasms. So we would have them in a sort of quiet, dark room to try and minimize that external stimuli. This little boy came in with tetanus, and when he first arrived, he was incredibly unwell. He couldn't eat or drink. He was miserable. He couldn't sit up. And at this point, I'd been caring for him for about a week, maybe 10 days. And normally when we came in and did our ward rounds, he would be, you know, so afraid that we would examine him and cause spasms that he would just sort of not want to engage with us at all. And he was, you know, just really withdrawn. But on this particular day, he was sitting up with his mum, and he was looking at me with his big eyes, like he was seeing me for the first time. And he kept saying to his mum, "Kawaja, Kawaja," which is the Dinka word for foreigner. And then he wanted to look at my hands, so he was taking them, turning them over in his, looking at my pale skin. And it was just so beautiful to see him starting to feel like himself again, and wanting to interact. And that was when I knew that he would get better, and he did. A little bit about life outside of the hospital. So like I said, we lived in a compound, 15 to 20 expats. We all had our own little hut or tuku. The facilities were basic, but they were more than adequate. We had shared bathroom facilities. There's no town electricity or water, so we had generators, we had a well, and we treated the water on site with chlorine so that it was safe to drink and to bathe in. We had two lovely local women who would cook for us, but we had to do our own grocery shopping. So normally on a Saturday morning, we would take it in turns to go out and do the weekly food shop. This was one of our cooks, Madalena. She was trying to teach me how to carry a watermelon on my head, but I was not nearly as good at it as she was. People were always interested in what I ate, so this is what I ate. There were lots of beans and legumes, lots of rice. We didn't have a huge amount of variety available in the local market, but we still, I think, ate very well considering. To keep ourselves entertained, we played a lot of cards. We played volleyball and badminton. And otherwise, we just sort of hung out. So I think being on mission is a really unique experience. It can be incredibly stressful, incredibly sad, but also, you know, we can have some really wonderful triumphs. And the people that I was on mission with really became like my family in that time. And I've, you know, kept in contact with a number of them, and I think that they'll be lifelong friends. So I want to come back to the title of my talk, Freedom is not a gift, but a product of the struggle. So this is the surgical ward where that quote was painted. And I think it really resonated with me because it encapsulated that idea of optimism despite the struggle. Because people really are struggling. They're struggling to improve their situation. They're struggling to feed their family. They're struggling to survive. And there were times when this image, you know, came to mind, and I thought maybe this is South Sudan. But then I would see glimmers of hope and of triumph. I could sit here for hours and tell sad stories, but I won't. I do just want to tell one more story, and it's about this little boy whose name is Lino. So he came into our hospital. He was 18 months old, and he came in with malaria and breathing difficulties. His malaria was treated within a couple of days, and he recovered from that, but his breathing difficulties continued. And despite the treatments, he just continued to get worse and worse. In spite of being actually quite unwell, he was just the most happy, playful baby around. So everyone in the hospital came to know Lino because you'd walk into a room and he would light up, he'd wanted to interact and play, and he'd have a big smile on his face. So we all kind of knew Lino. And he ended up in the intensive care unit because his breathing just became so severe. We tried all different kinds of medications. We did all of the investigations that we had available to us. I uploaded his case onto telemedicine to try and get advice from specialists, but we were all kind of scratching our heads, not really sure what was happening. And then one day, it was a few days before Christmas, I came into the hospital to do my ward round, and I could see he was just not looking well. He was really lethargic. His breathing was looking really terrible. And he really looked like he was about to arrest and stop breathing. So we rushed him to the resuscitation bed, and when we got him there, he had stopped breathing. So my clinical officer started ventilating him with a bag and a mask, giving him manual breaths. I listened, I put my stethoscope on, listened, tried to listen for a heartbeat, and I couldn't hear a heartbeat. So I started chest compressions, and our nurse started drawing up adrenaline. And as we're resuscitating him, I'm just thinking, please survive, please survive. More often than not, if a child stops breathing, if their heart stops, we weren't able to resuscitate them because we just didn't have the facilities to be able to escalate their care. So we gave him the first dose of adrenaline, and his heartbeat started to come back slowly. We gave him another dose, and his heartbeat became very strong. And then gradually he started to breathe on his own, and he recovered. An hour later, he was sitting up, having a breastfeed, smiling, being back to his normal cheeky self, which we were all just pulling our hair out, like, what's happening with this little boy? He had 4 more arrests just like this, and he had to be resuscitated. The other 4 times, I wasn't in the hospital. I was after hours or when I was elsewhere in the hospital. So he was resuscitated by the national staff, and each and every time they managed to get him back. Eventually, we had some advice from a respiratory specialist to try one more medication. And with this new medication, he slowly but surely started to improve. And he survived. He got better and he went home. Now, his survival wasn't a gift. It wasn't a miracle. His survival was a struggle. It was a struggle for him. It was a struggle for his mum. And of course, it was a struggle for us. But he survived. And he survived because of the incredible work of the South Sudanese staff. He survived because we had the medication to give him. He survived because we had electricity and generators to be able to provide oxygen, because we had the resuscitation equipment. So he survived also because of you and because of donors like you. And without your generous support, none of this work would be possible. So thank you for your ongoing support of MSF, and thank you for your time today into my presentation. That's all.
Thank you so much, Madeline, for your wonderful presentation about a wheel and your dedication and care. I particularly find it really touching to see this presentation about a wheel and the success of the hospital, because I was actually one of the people in the team that started that hospital. So it's really wonderful to see where it's come to today and the work that you were able to do there. So we'll be hearing more from Madeline in the question and answer after Arun's presentation. So now I'd like to introduce Arun Jigan, who works with Médecins Sans Frontières Australia as our advocacy coordinator. He's also a permanent facilitator for the emergency public health course at Epicentre, which is the MSF Epidemiological Research Centre in Paris. Arun has worked as a head of mission and emergency coordinator, and has worked in Yemen, Syria, Venezuela, Bangladesh for MSF, and in Afghanistan also, Iraq, Jordan, Lebanon, and Turkey in senior management positions for other NGOs. I'll pass to Arun. Thank you.
Thanks, Robin. And thanks to Madeline for that really engaging presentation. That last story about the child, struck a chord in all of us, I think. So thank you for that, Madeline. So good afternoon to you all. It is such a privilege to speak to you all today. In my former role as head of mission, one of my main duties was actually to negotiate with armed groups and with health authorities to see if MSF can have hospitals and healthcare in countries. And the first question they often ask is, how are you independent? Do you receive money from governments? Because we're not letting you in here if you do that. And it's because people like you, and I always direct them to people, to you all, to the supporters who give us money. And it helps my job a lot in the field, because I can easily say that, well, most of our money actually comes from private citizens who care and not from governments. And that is one of the most powerful tools I have as a head of mission, to say that our projects and our funding is actually independent, and we're here just for the people. So on behalf of myself, thank you, and thank you for making my job very easy, actually. So today, I'm here to speak about my experiences with refugees, and I'm here to speak about my experience with MSF, but also as a Tamil, as a Sri Lankan Tamil whose family and whose community fled violence in Sri Lanka and has sought refuge here in Australia. So I'll first start with the MSF experience, and I'd like to start at 2017 when I was in Bangladesh on one of my first missions with MSF. I went as a project coordinator in the capital. It was a project called Kamrangicha Urban Slum Project. Now this project, or this area, let's say, was one of the most densely populated places in the world. We're talking about 300,000 people, upwards of 300,000 people in 3.6 square kilometers. You can imagine how tightly fitted everything was in there. And we were providing basic primary healthcare to the population there. We had sexual reproductive health services for pregnant women. We had pediatric services for children. Fairly small kind of project, let's say 5 clinics. About 4 months into that project, I received a phone call from my boss asking me to go to the border of Bangladesh. He was saying that there's some violence that has happened, and there were reports of people fleeing Myanmar because of targeted violence against them. So little did we all know at that point what was about to eventuate, but I got on a plane to meet the team that was already there. And as I approached the border of Myanmar, it was absolutely like a zombie apocalypse. We're talking about hundreds of thousands of men, women, and children fleeing with just the clothes on their back. They were coming in by boat, they were coming in by feet, and some were swimming across the river that separated Bangladesh and Myanmar. It was clearly a population that was traumatized, and it was clearly a population that was fleeing violence. If you can imagine seeing thousands of people walking across a border, and in the background there being large fires, looking like explosions coming from that area, that was the scene that we saw. And we assumed at the time it was because the villages were being burnt, and this was later kind of confirmed when we saw the burnt clothes on people's back, the bullet wounds that we were treating, the stab wounds that we were treating, and also just seeing the shock and hearing the stories from the people at that time. But I think it was the look on people's faces that was the most relatable story. It was the look on people's faces that were fleeing violence. And I've seen that look before. I've seen that look before in my family, with myself, and with my community as well. This is the very common story of refugees who are fleeing violence. Now, over the next 3 months, over 700,000 people would seek refuge in Bangladesh and form what is now known as the mega camp. It's the world's largest refugee camp to this date. These refugees are known as Rohingya, an ethnic group that has been constantly persecuted and excluded in Myanmar. But this was by far the worst incident. I mean, I've lived in conflict zones before, as Robin mentioned before. I've been to Afghanistan, I've been to Yemen, and I don't like to compare countries, but in this case, it really struck me the magnitude and the size of this displacement when that many people were forced to leave their homes in 2 to 3 months. what are you supposed to do in a situation like that? What am I supposed to do in a situation like that? I worked for MSF. I was a project coordinator. I was responsible for guiding my teams and showing leadership and making decisions in what we're supposed to be doing there. In a situation where every human need, food, water, healthcare, shelter, all of the above is missing, is present, what choices do you make as a MSFer, or what choices do you make as a human really at that point in time? Now, I can tell you one of the quickest lesson that I learned was how quickly things change in that context. Now, me and the teams, we decided in the beginning we should do some primary healthcare units, and we put, I think it was 3 mobile clinics near the border so that people can get treated and get some healthcare. But then we quickly realized that this was doing nothing for the population, or it was doing very little. So we quickly pivoted to a water hygiene and sanitation strategy where we were digging boreholes, providing water care, because it was very clear that the most immediate need at that point in time was to ensure that diseases like cholera, acute watery diarrhea wouldn't spread in the camp. And the best way to do that is by providing water and hygiene and sanitation. Now, these decisions were changed on a weekly basis because of the size of the camps. There are so many stories I can tell you about what we faced in there, but I'll leave it there. But basically, yeah, I mean, we had so many choices to make on that day, and you can imagine my team and I were pretty overwhelmed by the choices we had to make. But I think rather than going on about the choices that I had to face that day, I'd rather talk about the choices that the refugees had to make. I would like to read to you a story of a Rohingya man that I met and the choices that he made on that same day while I was making choices about whether doing, water, hygiene and sanitation or vaccination programs or other things. These are the choices that this man had to make. His name is Nurul. So Nurul is a 40-something-year-old father of 4. And I first met him when he and his family were crossing the river as he was fleeing violence. This was back in 2017. I remember this scene almost like as it was yesterday. He was constantly negotiating each footstep with a child in each hand, the other tightly gripping a rope that tied him to another person up ahead, looking like a human chain of a Congo line walking across a river. He was lucky. His children held on to him and he held on to one children. Other children didn't make that. Other children, the current caught them and swept away. Nurul made several choices that day, or he was forced to make several choices that day. He chose to leave his home in Rakhine State. He chose to take a comb, soap, and 2 items of clothing, a pot, and a jerry can of water. He even chose which child he would have to help while crossing that river. Now, 4 years on, he lives in a refugee camp without the permission to work. His children are not allowed to get a formal education, and he is a citizen of no country, and he is still waiting. He is still depending on organizations for foods and handout. Organizations like the United Nations, like the Bangladeshi government and their World Food Program. He has been diagnosed with post-traumatic stress disorder and acute anxiety. His daily worries are, how is he going to get food today? Is his family going to be safe because of the violence in the camps? And also, whether he can ever return home or resettle in another country. These are his daily worries, and these are the daily decisions that he has to make in terms of what he's going to do today. Tragically, this is a common story for all the Rohingya refugees. 4 years on, their situation has not improved at all, and COVID has made it even worse. Can you imagine being in already a restricted context where you can't get food, you can't work, and you're dependent on people, to then be put under lockdown, not able to leave your block? It's toughest in the best of circumstances, and I call the best of circumstances maybe the circumstances that we live in, where we have a formal economy, where we have access to food, where we have access to other support services. But in a context where you're literally dependent on other organizations and you can't leave your home, it doesn't work, and it is a very, very trying situation for them right now during COVID. And I think while the physical wounds of the violence have healed, this disturbing situation has caused widespread mental health issues for the Rohingya. They are mentally wounded. In fact, last year, MSF has recorded a 61% increase in mental health consultations. MSF in the camps, in terms of what we do there mental health wise, it includes psychiatric services as well as psychosocial services and individual, family and group counseling sessions. We do see a little bit of an improvement when we do these therapeutic functions and medical care related to mental health. But we can see that the mental health situation isn't something that's just going to go away because we provide care. It does provide respite and it is very important, but their situation is what's causing them this problem. Now, the mental health services that MSF provide in that camp and the services that your donations and support and contribute to are enormous. They provide a small bit of relief and support during what is likely to be the most important journey a person can ever make, and that is seeking refuge. And I can speak on behalf of my own community and behalf of my own, just having some proximity and having some care during what is an uncertain time for you means all the difference in the world at that point in time. Now, while Nurul and the Rohingya and other refugees don't have many choices, we have a choice, and that's you and I. We have the choice to use our privilege and the resources to do what we can. But ultimately, we have the choice to listen to refugees. And today, you made the choice to listen to me and the story of Nurul. And for that, he and I would like to thank you and thank you for your ongoing support for MSF. I'll pass it back on to Robin. Thank you again.
Thank you very much, Arun, for that touching and human window into the challenging conditions refugees face. And also I'd like to say thank you to all our speakers, and we hope you appreciate hearing their experiences and the impact that your donations and support have created. Now, I'd like to move to our question and answer session. So thank you very much to all of you for pre-submitting your questions. This will allow us to cover a broad spectrum of inquiries and give you some more detailed information about MSF and the great work our field staff undertake daily. We'll attempt to get to as many questions as possible, and I apologize in advance if we're not able to address each one. Now, I'll read out the questions and pass to our panel. So the first question we have is, how does MSF decide where to go in the world, especially which causes or issues MSF decides to address? I'll pass that one to Jennifer.
Sure. So taking this from a very big picture level, on an annual basis, MSF globally looks at, basically what are the resources that we have available to execute our projects? What are we doing right now? What's going to close? And then how do we make decisions globally around, what the balance of programs that we want to have? So how much conflict are we responding to? How many medical emergencies are we responding to, et cetera? So that's from a very big picture level. We then have a window in that planning where we obviously plan for emergencies. We're an emergency organization. I think we were a little shocked on how big a window we needed last year with COVID, but that was obviously deeply unusual. We also plan for openings. So Arun was talking about his role as a project coordinator, and when he played the role as head of mission, you will hear from project coordinators and heads of mission on what they're seeing on the ground and where they think the needs are. For instance, when I was a project coordinator in Pibor in South Sudan, we were seeing really high rates of HIV, and yet it was a really itinerant group of people who we were responding to. So the idea of trying to get some continuity of HIV treatment was really difficult. And so while, we all on the ground wanted to address this issue, we really had to have a tough debate about whether or not that was the logical thing to do in that context. In the end, I did not win, but those are the discussions that happen around that sort of annual planning and big picture discussion.
Super. Thank you very much, Jennifer. Next question for you, Arun. As an emergency organization, how do you get invited in, and how do you decide when to leave a project?
It's a very good question, and I'm going to give the annoying answer of it depends on the context. But how do we get invited in? And I think the guiding principle for me is always ensuring that it's the population that we're working with that invites us there. It really depends on if it's a conflict, a natural disaster, an outbreak. For a natural disaster, it's usually very easy to get invitations because there's a huge need and governments want that help. And so you can quite quickly go in there. The Ministry of Health, sometimes even from the Prime Minister or President's office, there's a request for people to go in there and you can help. I can give you an example, like Bangladesh has been quite a restrictive environment for NGOs, but during that influx, they opened up the invitation for everyone to come and help because it was just beyond the scope of one government responding to it. Speaking more, I think what would be more interesting to speak about here is actually what about when you don't get the invitation from the government, or what about when you're responding to a situation where the government's actually failing the people and they don't want you there doing it? How do you do that? Well, it's long negotiations, but the main thing is that we're there to treat people. We're there to treat humans. We're there to treat everyone that is in need, and that usually that can speak to an audience. That can speak to the Ministry of Health. That speaks to doctors and people on the ground that can provide access. And more often than not, we can get access into areas, but in some cases, for example, in Syria, for the first few years of that conflict, we found it very difficult to get access into there. And so we turned to remote programming where we supported local partners in there. And we don't do that often because we try to do it ourselves, but we try a way, we find a way to get invited in if that invitation isn't standing. But the main thing is, as long as the people or the community and the patients, let's say, want us there, we usually get an invitation. How do we decide when to leave a project? Again, $1 million questions, eh? But choices and decisions that we have to make on it, that I've had to make on a monthly basis. But I use two main tests, and one of them is following the epidemiological curve. I look at the burden of diseases, the mortality and morbidity on a community, and see whether we've achieved our target of reducing that or not. So, for example, if we're there for a cholera outbreak, we can easily see where we are in the emergency. Has the cholera outbreak kind of subsided? Has it gone or not? So we use that as a very good test to see whether we're needed there or not. But the other one, and I think this is a very important one to mention, is context. Sometimes this health situation might look okay on paper, but there might be other factors around there. Exclusion, there might be the prospect of violence or instability. And then we'd want to be in that country and we'd want to kind of stay onwards. So I use the context and I use the epidemiological kind of indicators to see whether we close or not.
Thanks, Arun. Yes, and sadly, in fact, in many cases, we don't reach those and we stay for long periods of time as well as the conflict or the situation continues. Yes. There's a question for Madeline. How do you build rapport with local staff and patients?
Thank you. Yeah, I think for me, one of the important things when I went into my project in South Sudan was just to approach it with this sort of idea of mutual respect, and also to like acknowledge what they were already, the way that they were doing things. So I took some time to just sort of stand back, see the way in which the staff were running, their services, and just try to value add rather than coming in and trying to change things. So I think the national staff really appreciated that kind of approach of, I had as much to learn from them as they had to learn from me. I also took the opportunity to try and just get to know them. So, start off with a safe topic like, asking them about their family or about their education. And in many instances, my staff would then start telling me about their experiences living through war or living in refugee camps. And in terms of getting to know or building rapport with patients, I tried to learn some of the local language, Dinka. And I think, when appropriate, I would try and use that with the families, which they all thought was hilarious, me trying to greet them in Dinka, trying to ask them, has your baby breastfed? So I think, again, just being respectful of their culture and their customs and of their language, and just trying to learn what I could from them.
Thank you very much, Madeline, for that. And next question is for Jennifer. How has COVID impacted MSF projects? I know you've touched on that a little bit already, but perhaps some more.
Yeah, I think for those of you who have seen me on a webinar over the last year, you will have heard me say this already, but I thought it was great. The head of our operational team in Geneva actually said, well, now, you know, all projects for MSF might not be COVID projects, but they're all COVID impacted projects. You know, we've seen sort of a long-term, it's almost a long-term response at this point, and it goes with what a lot of you all have seen in the audience, which is a scramble for personal protective equipment, making sure that, as I mentioned earlier, that we actually have access to that to protect our teams. That is both because we have a duty of care to our field teams, but we also have, try to attempt to create continuity of care. So there's been a real focus on PPE and infection prevention and control. Tracking the virus, obviously trying to secure tests, trying to secure rapid test, the Gen Expert cartridges and materials that we need has been a big deal as well, and a big focus. Again, same here, you know, trying that we're all following the curve of the virus, and so making sure that we had an understanding of how that was evolving epidemiologically. Now, you know, we are in the vaccination phase. There was a lot of discussion around access to vaccines for humanitarian organizations. We are ramping up our ability to vaccinate in the field. And the big call out is for oxygen therapy. A lot of what I'm sure you're seeing in, well, you've seen in the US, you've seen in India, is when there is a big outbreak, there is not enough oxygen therapy to treat critical patients. And so that's a big discussion as to how do we actually do that in low resource settings. So that's how COVID, you know, has impacted. And then there's just in all of that, making sure that COVID doesn't overtake the projects that we're actually doing. The one thing I will say is that, you know, one thing we have noticed quite significantly is healthcare for women has deteriorated because women are not presenting as much at healthcare centers. And that's one of the many subtle things that we're looking at as we move forward.
Thanks, Jennifer. Next question is for myself, in fact, so I'm very pleased. So how do you look after the mental health of your workers? So, not unsurprisingly, you know, the health of our people is really important to us, particularly given, as a bit like you've heard, the challenging places and situations that they will face. So our care starts with our recruitment and doing assessment on people's health and ability to be successful, working for Médecins Sans Frontières. We also provide stress management training with a psychologist prior to their departure. We provide access to psychological support, or any support, in fact, in the field, when they're in the field at any time. And on their return home, and importantly, in fact, regardless of how much time has passed since somebody's last assignment, if they need support, you know, we will provide support for our staff, because they are so important for us, and they are what makes one major part of what makes the organisation able to provide medical care. I'll now have moved to the next question, which is for Madeline, for you this time. From your personal experience, what is the most important thing that we as supporters should understand?
I think there's probably a couple of things. I think first of all that the MSF supporters are making a huge difference, and you know, as a few of us have highlighted today, really none of this work would be possible without your kind support. I think another thing is that the face of MSF, you know, what you see is probably, you know, the people sitting in front of you on this panel today, but actually, you know, it's the national staff on the ground who do so much of the work, and I think that's something that is really important to acknowledge as well, is how valuable they are. Yeah, I think those are probably a couple of the important things that I would say.
Thank you, Madeline. Next question, again for me. So are our field workers paid, or are they volunteers, and do local staff earn a wage? So for all our people from Australia and New Zealand who work overseas, they receive a salary based on our global, we have a global remuneration system. The salary is modest, based on our volunteer spirit for what we do. But we do also provide travel, accommodation, and project costs while working in the field. And also for our local colleagues in country, they're also on salaries based on the standard salary levels for their country, for the doctors, nurses, and finance, etc. So they're also remunerated for their excellent, their wonderful work and their professional services they provide to our patients. I think we have a couple more questions. I'll just move over. Another one for me. I get 2 in a row. Very nice. What is the usual length of time an MSF field worker may be on an overseas mission, and how many staff at any given moment may be overseas? So in general, for the start, the average time people spend in the field is around 6 to 9 months. With more experience, this can vary from 3 month emergency assignments through to 2-year country management positions for our senior staff. As you imagine, surgeons and other specialists actually usually do shorter missions of maybe 2 to 3 months. And this is mostly due to the workload and be on call, for example, 24 hours a day. And that's not sustainable over a long period of time. Currently, we have about 55 staff in the field at any one time at the moment. However, this is lower due to COVID and the travel access and challenges that Jennifer talked to early on. But the long-term average is usually around 70 people in the field at any one time. Now, a question for Arun. So when MSF is speaking out or bearing witness, how do you ensure we're being factual and impartial?
Yeah, good question. I think, first of all, I think the bearing witness component for MSF is one of our most powerful tools. It's actually in a part of our DNA, really. We're not just a medical organization. We call ourselves a humanitarian organization with a medical toolkit. So it's not just patients that we're treating, but also how are we serving their best interests and relaying their story to the world and speaking out sometimes when it's necessary. And I think the most important thing is focusing on the medical data and getting it directly from the patients themselves. And we've got several examples that we can share with you. They're on our website. There's the Nauru patient mental health report. There's the Rohingya mortality survey. And in South Sudan, we did a report on rising SGBV cases. But the main point here was that we decided that the medical care that we were doing wasn't enough, and that we needed to show the world and show the other people that this situation cannot be left unchecked. And the way we control that to being factual and impartial is strict processes. For example, when we do surveys, and for any nerds out there, we choose the sampling method. That's really important. Are we doing a comprehensive sampling method? Are we doing systematic random sampling? Depending on which surveillance system we use, we make sure that there's a process in there. So we're not just cherry picking details, but there's a process to collect the data. I think the other aspect is that when we're taking, let's say, qualitative information from people, like, for example, patient testimonies, or what we sometimes call red flag testimonies of violence against civilians, sometimes you're putting patients in a very compromising position, right? Like, we're treating them at one point, but we're also collecting a testimony. So we make sure that there's processes in place so that we don't put patients in a compromising position. For example, the doctors and nurses don't take those reports. We usually get another team. We get consent done beforehand. So we do this. We get factual and impartial information by just ensuring there are strict processes and there's verification methods at every step of the way, keeping in mind that I think patient confidentiality and doing no harm to the patient is at the forefront of these guiding principles that we have.
Yes, thanks, Arun. Yeah, I think just by being there and is the way we can speak out. Yes, by being there and seeing our patients and knowing what they're going through. One more moving to the last question, and this one's for you, Arun. How is MSF advocating for equitable access to COVID vaccines?
This question it's a multi-layered question, because we do it at many levels. And I think at the international level, at the multilateral global level, we're pushing for a humanitarian buffer stock. And that's together with UNICEF and Gavi and the World Health Organization. We're really making sure that there's a buffer stock in the global collection of vaccines so that people who don't naturally fall under a government vaccination program, refugees, migrants, people on the move, people that are just generally excluded from programs, have access to COVID vaccines. And this is something we're really pushing for, and that we'll be a part of when that time comes to applying this. That's at one level. I can give you examples of at the country level. For example, we're trying to provide visibility to contexts where there is a clear-cut exclusion of a population. I can give you an example of Palestine, for example. The whole country of neighboring Israel was fully vaccinated before all the health workers in Palestine were vaccinated. And so highlighting these to the world and showing in media, in our bilateral briefings, is one way that MSF is advocating for more equitable access to COVID vaccines. But I think more than COVID vaccines, I want to just have a general reminder that the patients that we're seeing and the people that we're working with are already excluded from healthcare. So the vaccines might not reach them immediately in the best of circumstances. So it's not just vaccines that are required to help fight this pandemic, but it's also medicines, diagnostic tools, and the things that are going to allow health systems to cope while this massive global vaccination program continues. And that might take several years for that to happen. So we're really pushing for not just vaccines, but medicines, antivirals, diagnostics, and other equipment, medical tools really, to be available. And there are many initiatives that are being pushed forward right now with MSF and by the world for this. One of them is an intellectual property waiver at the World Trade Organization for these medical tools. Other ones are for donating more to the global fund for vaccines. So these are some of the ways that MSF are pushing for it, but it's at a very international, I say, country level. And also at even in MSF Australia, we spend quite a considerable amount of time advocating for this too.
Thank you. That was really interesting to hear, an interesting question. Thank you very much for the question too. So that was our last question. So I'll pass to Jennifer for a wrap up. Thanks, Jennifer.
So thank you to all of you for spending your lunch hour or whatever it may be with us. We really appreciate it. And thank you to Arun and Madeline. I think we can all recognize that both of their testimonies were really completely from the heart, and I think represented the people that we serve very well. So we appreciate you sharing their voice through you with such respect, kindness, and compassion. I want to thank you again for attending the briefing and submitting your questions. It's really important that we understand what you are interested in hearing about. So let us know how you think that this went. And the recording of this video is going to be sent around in a few days, along with a short survey we would be very appreciative that you could fill out. So if you complete this, of course, we can incorporate your opinions back into the way that we shape and engage with you all in the future. And share more incredible stories from the work that is happening outside of Australia. So Madeline, thank you very much. We say au revoir to you, and to Arun and Robin, I'll see you in the office later. And thank you all.
Thank you all very much. Thanks, Jennifer.
Thank you.